Hello and welcome to Alterations in Musculoskeletal Function. In this section here, we're going to talk about some of the anatomy and physiology review of the musculoskeletal system, and then we're going to go into looking at some specific pathophysiological problems that occur with our patient's musculoskeletal function. So let's go ahead and get started. Just as a background and as a review, let's talk a little bit about the structure of our musculoskeletal system, beginning with the bones that give form to the body and permit movement. So without bones, we'd just be kind of like this big massive mound of flesh and not be able to have any movement or have any structure. They provide support for the attachment of muscles. So when a muscle contracts, it's going to cause motion, it's going to cause movement because it is attached to bones. If it was just simply freestanding muscle just sitting there in your body, it wouldn't cause any movement because it wouldn't be attached to anything. The marrow is the site of where we have our blood cell production, so really important part of our skeletal system, and you can see some of the major areas where that occurs. Bone tissue is a rigid kind of a connective tissue that is comprised of a number of different things, like the bone cells themselves, the fibers. We're going to talk about those bone cells and the different kinds. A ground substance, which gives it a little bit more of a structure and hardness. And then minerals, mostly calcium, that are making up this hard structure of the bone that's going to allow the bone to give us some strength and structure to the body. Collagen increases the strength of our bone, and the ground substance acts as a media for all of these different pieces. Now, as far as our cells go that make up the bone, we have the osteoblasts, which are the precursors to our osteoclasts, our actual bone cells. So these are going to be the bone producing cells. They're going to be the cells that are going to produce bone here in the future. They are responsive to parathyroid hormone. So PTH is parathyroid hormone. They produce calcitonin when they're stimulated with vitamin D rather. And vitamin D is one of those vitamins that we are going to manufacture. We can take it in the diet, but we can also manufacture it by exposure to sunlight. They're going to help to mineralize our newly formed bone matrix, and then they help to build the patient's bone. So here we're showing some of the cells in that bone matrix. You can see how bone really is not a solid organ. When we think of bone, I think most of us think of something that's very hard and solid like a rock, that there is no porosity or porousness to it. But in fact, bone is very porous. It's very vascular, it's very porous, and there's a lot of room inside that bone for both vasculature and for the bone cells and the new blood cells to be able to produce. This is an important concept because one of the ways that we can treat a patient who has a fluid volume deficit is to put a catheter inside the bone, and then fluid is then absorbed through the bone. Okay, the bone doesn't absorb it, but these little, you can see all the little pockets here, all the little openings, the porosity to the bone allows that fluid to move into the bone and then be pulled out into the vasculature. So it's another way of getting fluid into the vasculature. That's called an intraosseous infusion. Osteoclasts, these are the major cells of the bone. Okay, so they're going over the bone surfaces, and they're going to reabsorb areas, bone areas, dissolve the bone. Calcitonin is going to help these to bind to cell membranes and loosen cells from its bone surfaces. So the idea is that we want to have our bone continually rebuilding itself, just like the rest of the cells of the body, continually rebuilding, so that we're building up stronger and stronger bone, and we're keeping that bone nice and strong. So we don't want our bone to get old and brittle over time. Instead, we want it to remain nice and strong, and osteoclasts are going to be a big part of that process. So when we had talked about the tissues of the body, the regular, tissues of the organs and of the skin, etc., we talked about this process of apoptosis. There's also a process that's going on in the bone where the bone is being resorbed over time and being replaced by new bone cells that are going to help to make it stronger and keep that bone from growing old. Now, osteocytes, and this is going to be the cell that is going to be transformed from our osteoblast. And remember, the osteoblast was kind of that precursor cell that is going to then turn into the osteocyte. The osteocyte is going to be the cell that's actually making up the bone. So it's going to start to harden as a result of having calcification process going on from the minerals that are inside the bone, and that's going to create the actual bone and cause that bone matrix. This is showing some osteocytes here, and they are moving with osteoclasts inside the bone here, inside the bone matrix. So you see that nice solid bone matrix. Again, very porous though, and we see our osteoclasts that are moving within that bone matrix. So then here is just some different pictures of what these different cells might look like. On the left-hand side over there, we have the osteoblasts, and they're moving along the outside of the bone there in order to be able to move to the areas of the bone that are going to grow. Osteocytes then, within the inside of the bone marrow, are starting to, or inside of the bone rather, are starting to help to regenerate the bone. And then lastly, we have our osteoclasts there as well over on the right-hand side, showing the reabsorption of our mineralized tissue inside the bone. Bone remodeling, this is the process of restructuring the bone so that the bone maintains its integrity. So, we get these little microscopic injuries that occur on a regular basis. Maybe you slipped and fell and you landed on your arm or something like that, and it hurts for a couple days. Well, you had some microscopic injury occur to the bone, and then what's happening in the body is that the bone is remodeling. It's rebuilding that area that had the little microscopic injury. So even though we don't have a fracture, we don't have some kind of obvious injury that we can take a look at, we can have microscopic injuries occurring to the bone, and we need to repair those. And that's this process called bone remodeling, where we're rebuilding the inside of the bone. And that's going to be done by our osteoblasts, which are then going to become osteocytes, and the osteocytes then are going to become the bone itself. Kind of a three-phase process here, especially when we're talking about this here. We're talking about a process where we're going to see maybe a larger injury start to be remodeled, like in a situation where a patient maybe has a fracture. We have the activation. So first of all, there's an activation, and in many cases it's going to be caused by the person having an injury. So there could be that microscopic injury. It could be something else like stress that is causing that activation of the bone remodeling process. Then the resorption, we're going to start to see those osteoclasts start reabsorbing or resorbing into the bone, leaving a cavity. And then the osteoblasts are going to lay down the new foundation, which are going to become our osteocytes. So this is just showing, the picture is showing this same process in a visual format. So we have the osteoclasts, they digest the bone there, they're starting to eat away at the bone in the areas where we have a problem. Now, in this picture here, it talks about it as being apoptotic osteoclast. So we talked about apoptosis before. That's the process where the body breaks down old tissue, replaces it with new tissue, so that we can rebuild areas of the body that are injured, have little micro injuries, or that are just old and are becoming weak, etc. So then we have the pre-digestion. We have that pre-osteoblast laying down inside that area that has been cleaned out. We're going to start to see the mature osteoblasts start to turn into our osteocytes in the formation stage there. At the same time, we're also having more osteoblasts forming on the outside. So as that bone starts to heal, we may see some deformity on the outside of the bone, and that's expected at that point in time. Then lastly, we get back to the bone state, and now we're into a normal state of what the bone is going to look like. Now, again, this shows a pretty big indentation here being eaten away by the osteoclast, but that's not usually the case. In other words, if you have, and I'm just talking about the regular remodeling process. So if we have the regular remodeling process going on, just because there's an area of the bone that's old, needs to be regenerated, we don't take big chunks out of the bone and then rebuild it. That's going to make the bone weak. So this is done on a very microscopic level. So when we're looking at this, it looks like it's, like a big chunk of the bone, in relationship to the picture, but it's not. Okay, it's going to be a very small part that is going to be involved in any one time. Remodeling, on the other hand, is a little bit different than repair. Repair occurs when we actually have an injury. So we could have a fracture, for example. Fracture is a type of an injury that can occur to the bone. So we're going to have some kind of an injury occur to the bone. And now we need to heal that bone up so that it can be strong again. We're going to take a look at that process here in a moment. Here's some of the different pieces of that process. But let's take a look at a picture of that, because at least for me, that makes a little bit more sense as seeing it in a graphic form. Okay, so we're taking a look here at the broken bone. So letter A at the top there, we have a fracture. This person fell down and, let's say, broke their forearm. So we have bleeding occurring at the ends of the bone, and then there's going to be a hematoma that forms around that area. Now the hematoma is trying to isolate that bone break, and it's trying to isolate the area, keep the bleeding from occurring. Remember, the bone is a very vascular organ. So this hematoma is going to be the clotting process. Remember what happens with inflammation. We get vasodilation, capillary permeability, and clotting. Okay, so the clotting process is occurring here, and that's where that hematoma is fitting in at this point in time. Now, in letter B, that hematoma is going to start to form into a fibrous network. Okay, now keep in mind this is still an unstable fracture at any point in time here. It has not started to bind bone back together here. So we're talking about the very early stages. This starts to occur almost immediately after the injury and is going to continue for the first few days of the injury. Because we still have the hematoma forming there, we're still going to have swelling at the site. And remember, again, that's from inflammation. Inflammation causes capillary permeability, so fluids leaking out of the capillaries causing swelling at the site. And this would be the reason why when you fracture a bone, oftentimes a physician may be reluctant to cast it. They may put a splint on it, but they may be reluctant to cast it until it's been a couple days after the injury to let the swelling go down. Next, we have our osteoblasts start coming into the bone. So that's the little cells you see there on letter C, little cells that are going into the area. Those are our osteoblasts. They're starting to come in here. They're starting to lengthen out those collagen strand. They're starting to put some calcium down so we can start to rebuild that bone there. Next, we have our what's called a callus formation, and the callus formation is these osteoblasts that are now starting to turn into osteocytes, starting to rebuild the bone, and we're starting to rebuild the bone in that particular area, while at the same time the osteoclasts are working in there to get rid of the old bone that has become injured and is no longer going to be effective. Lastly, we have letter E, the remodeling process, and the excess callus is going to be reabsorbed by the body, and the bone is going to be deposited and rebuilt. In most cases, there will be some evidence. So as you see in letter E there, it looks a little bit different, and that's not how it would look on an x-ray, but it looks a little bit different than the bone did before. It doesn't mean it's weaker, but it does look different at the site than it may have previously. So oftentimes we can tell that there's been a previous fracture, even though we had full healing and you can do full weight bearing and there's no restrictions. So a fracture is literally a break in the continuity. So we have a bone that has been broken in some way, and we call that a fracture. If the fracture goes all the way through the bone, we call that a complete fracture. If the fracture does not go all the way through, we call that incomplete. Next to incomplete, it also talks about a closed or open fracture. Closed fractures mean that the fracture is underneath the skin and the skin has not been penetrated. If, however, there is an opening in the skin, we call that an open fracture. Comminuted fractures are fractures where we have the break in two or more fragments. So in other words, there's multiple breaks that have occurred in that area. So more like a shattering of the bone than a fracture or a break. A linear goes along the parallel axis to the bone, whereas oblique goes at an oblique angle to the bone shaft. We're going to see some pictures of these. And a spiral fracture kind of curves around the bone shaft. Some additional classifications we use: transverse means a horizontal break straight across that bone, a green stick fracture, and just as the name implies, like a green stick. So if you were to go outside in the spring and you grab a stick off of a tree that is still green and try to bend that stick. Now, if that is a dead piece of wood, it's going to crack. It's going to break in half and you'll have two pieces of wood. However, if that wood is green, it's going to tend to bend, and it'll splinter on the outside of the bone, but the bone will just simply bend. This is what we call a green stick fracture. It's a kind of a bending of the bone. It splinters the outside of the bone matrix, but the inside of the bone matrix is still solid. This happens frequently in children because their bones are a little bit more flexible than in adults. Usually in adults, we don't have that kind of flexibility to have a green stick fracture. A pathologic fracture is a fracture that occurs in someone who has some other kind of disease process that has already previously weakened the bone. Lastly, one that we hear a lot about is people talk about stress fractures when they're exercising. And a stress fracture is caused by repeated microfractures inside the bone caused by repeated stress. So let's take a look at some of these different types of fractures in our pictures here. Letter A is an oblique fracture. You notice that the fracture is at an angle to the bone. It's not straight across the bone. Instead, it's coming in at an angle. It looks like here it's almost like a 45-degree angle to the length of the bone, and that would be called an oblique fracture. An occult fracture, which is illustrated in letter B. Occult fractures are going to be small fractures, or it could be, I guess, a larger fracture, but it's a fracture that we don't know about. So maybe the patient has fallen a couple times or something like that, and then they stop complaining of pain. So it wasn't painful anymore. So we didn't take him to the hospital and get an x-ray. Well, at some point in time, we go in and they get an x-ray for something else and say, oh, look, there's an occult fracture. It's a hidden fracture, one we didn't see before. Over in letter C is an open fracture. Now what they're illustrating here is that the bone, in this case the tibia, is sticking through the skin in the leg. So it's not only fractured, but the bone end is sticking through the skin. So that's opening it to the outside of the body. Over here on letter D, we have a pathologic fracture. Pathologic fractures are going to be fractures that occur in people who already have weakened bones for some other reason. So maybe your patient has a disease like Paget's disease, which weakens the bone matrix, and the patient then develops a pathologic fracture. That can happen just from standing up. It can happen from turning over in bed. It can happen because they sat down on a chair. Okay, so these are the kind of things that can cause a pathologic fracture when somebody has weakened bones. Letter E is showing comminuted fracture, where we have multiple fractures in that area, so it's more like a shattering of the bone. Letter F, I don't really think it shows the spiral fracture very well, but a spiral fracture is like a twisting type of fracture. So the bone is actually being twisted. Athletes will often have a spiral fracture because they plant their foot and turn. So maybe in football, somebody plants their foot and then they twist around to try to grab the ball. Now, if they do that with enough force, it's going to twist the bone and the bone will fracture. Transverse fractures, letter G, that's just straight across the bone there. There's a green stick illustrated in letter H. You see it's just kind of a incomplete fracture of the bone. It's just kind of a little crack in the matrix of the bone. And oftentimes it may look more like we actually have a splintering of the outside of the bone rather than a crack, which is illustrated here. Lastly, we have an impacted fracture in letter I. Impacted means it's being pushed into some other structure. In this case, it's being pushed into the hip joint. When a patient has a fracture, they can have injury to the surrounding tissue itself, and that can cause a hematoma to be formed. And this is a normal part of the process of healing of a fracture, is we're going to get hematoma formation. But that hematoma then could cause swelling at the fracture site and can cause additional complications. The bone injury is going to it's going to trigger the inflammatory response. We're going to get a callus formation, and then we're going to start to see that bone healing occur. So when you're looking at the bone, we have a lot of structures that are around the bone as well. So if we had an injury, maybe we had a fracture in this joint area, that could cause a lot of secondary problems in the joint. So if we have swelling in that joint, if we have swelling in that bone area, it could cause some problems with the muscles and the joint fibers itself, etc. So there's a lot of pieces that can be involved. The other thing that this is showing here in this picture is we come down the bone. If you're coming down the bone from the top, the end part of the bone here, right before it goes into the joint, so right above that little blue mark, that blue mark is supposed to be some cartilage on the outside of the bone that keeps the bone ends from rubbing together. But right before that, this end that kind of expands outward, that kind of bulbs outward a little bit at each side of the joint, those bone ends are going to be the area of the bone that grows. That's called the epiphysis. So symptom-wise, obviously this is a fracture here of the patient's at least forearm, if not wrist. So, and this is also a displaced fracture. You see the unnatural alignment of the forearm there. So, one of our first things when we see something like that is, wow, we want to get that thing back where it belongs, right? Because it's in an unnatural alignment. So we may have numbness up to about 20 minutes after the injury. That's a protective mechanism of the body to try to keep us from having extreme pain, because obviously it's going to hurt. The unnatural alignment we see here, and then the impaired sensation. So there could be some nerve involvement that's causing impaired sensation. Even if we don't have unnatural alignment like we do here, where we have a displaced fracture, just having the fracture itself is going to cause swelling at the site. Nerves run right along the bones so that we can have impaired sensation from that aspect. Obviously, there's going to be tenderness and pain. Muscles will go into spasm in order to try to protect that bone. So the bone has been fractured, muscles go into spasm to try and keep the bone ends from getting fracture or getting worse injury to them, and that's why we get the muscle spasm. But expect muscle spasm to occur with every kind of fracture you see. Swelling obviously is going to occur at the site, and that's even part of the normal inflammatory process and it's part of the normal healing process of a fracture. Our treatment is going to be that we need to get the bone ends back into a normal alignment, and then we need to have some kind of fixation device that's going to keep the bone in that natural alignment. So we can manipulate the bone in a closed manner and just simply from the outside of the body put the bone ends back where they're supposed to be, and then put a cast on or splint on the patient. Then if that's not possible, so let's say for example the bone ends are too far away from each other and we can't fix it, like the previous picture, probably would not be able to be fixed by just manipulating from outside the body. So then they take the patient to the operating room, and in the operating room they're going to cut open that area and they're going to put the bone ends back where they belong. Now in this case here, this is probably a comminuted fracture where we have multiple fracture segments. So what they needed to do is they needed to apply an external fixation. Sometimes the fixation can be done inside. In other words, they put in plates and screws and wires and all that kind of stuff to hold the bone ends together. But in some cases, that's not going to be sufficient, and we also need to have a device on the outside of the body to keep the bone ends where they're supposed to be. And that's what this is, and it's called an external fixation device. So this is holding the bone ends where they're supposed to be. Now this device is going to stay in place for a period of weeks, and then the surgeon is going to take it off of the patient, and we'll have hopefully a little bit more healing process that has occurred at that point in time. This slide here is just showing a little bit, giving a little bit of information here about hip fractures and the post-op care of hip fractures. Obviously, the care of our fractures and the details of the care of our fractures is going to be covered in more depth in other courses, but just to give you an idea of some of the different complications that we may see with our fractures. Now, a hip fracture, obviously, we've got a big bone that's involved. There's going to be a lot of problems with mobility, getting the patient up and ambulating. But let's say that even you've got a younger patient who fractures their leg and they don't want to get up and move around. They don't want to use the crutches. They just want to lay in bed. Okay, we're going to have additional complications that are going to start to happen because of that. So when it says nursing care here that we want the patient to cough and deep breathe every 2 hours, that's because we're trying to prevent the complication of the patient developing pneumonia or other respiratory complications by simply laying in bed for extended stretches of time. Stockings and compression devices to the lower extremities to prevent a deep vein thrombosis or venous stasis. Okay, so the patient's just laying there. We talked previously about Virchow's triad of risk factors for blood clots and pulmonary embolism. Well, immobility is a big one. The patient's also had an injury that would cause an increase in coagulation, and it would also cause vascular injury. So this patient has Virchow's triad of risk factors. So we're going to have to do something to help to mobilize the blood flow, even if we can't get up and mobilize the patient. We are going to turn the patient from side to side. If we were to leave the patient laying like she's laying right here for the next week until she feels better, she's going to have all sorts of bed sores from laying on that side. So we need to move the patient every 2 hours. In this case here, it's talking about maintaining leg abduction. With a hip fracture, we need to keep the legs apart. Otherwise, it'll pop the hip back out of the joint. Circulation and neural status checks. That's true of any fracture, that we want to check the neurovascular status beyond, and the circulation beyond that fracture site, to make sure that the swelling is not causing an impediment of those things. Pain control, mobilize the patient ASAP. We want to get people up and moving around as soon as possible to try to prevent those complications listed on the left side of the screen. Dislocation is when we move those bone ends out of the normal places where they're supposed to be, and now we have a, well, it's probably better just to show you than to try and describe it, but we have a displacement of the bones. They're not where they're supposed to be. We've lost the contact with that articular cartilage in the joint. So we're talking about joints now becoming dislocated rather than the midsections of bones. Let's take a look at an x-ray that I think is going to make this a little bit more obvious to you as to what this means. This is a dislocation of the elbow joint, and what you're seeing here is you're seeing the bones. They're not supposed where they're not supposed to be. Those bone ends are supposed to be lining up in that joint. So look at the picture on the left, and you notice that there's a bone that comes down. The humerus is coming down, and it has kind of like a cup. Well, the bone on the lower part of the picture is supposed to be going into that cup. Okay, so that's the articular, that's the area that makes the angle, that articulates. Those are supposed to be together, and they're not. So this is a dislocated elbow. These are very, very, very painful because there's a lot of damage that's going to occur inside the joint in order to allow that to happen. So not only have we moved the bone out of the position it's supposed to be in, painful, but we also probably damaged ligaments or stretched them in order to get there. That's painful. We may have even damaged some tendons in the process. That's painful. Okay, so lots of little damages occurring in here that made this happen. So that's going to be a big problem. That's going to hurt a lot. That's going to be very uncomfortable for the patient. Let's take a look at some questions then. A 70-year-old female with osteoporosis fractures her leg at a location of pre-existing abnormality. She reports that a fracture occurred following a minor fall. Which of the following best describes the fracture? So if you answered C, it's a pathologic fracture. Break of at a site where we had pre-existing abnormality. So the force that was applied would usually not fracture a normal bone, but it does fracture the bone in this area because we have a weakening of the bone for some pathologic, some disease process reasoning. A 32-year-old obese male begins a jogging regime. A week after beginning, he fractures his leg. This is referred to as what type of fracture? And I don't know if it shows up on your screen, but on my screen it looks like green stick is highlighted. Okay, don't let that influence your decision. It's a fatigue fracture. A fatigue fracture is caused by an abnormal stress or torque that's been applied to the bone. So this is the kind of thing that happens with people who have those stress fractures from running. Okay, so running is a very common situation where we may end up with having a stress fracture. And a stress fracture simply means we're stressing the bone more than, or fatigue, and this, is another term that's used for it. We're stressing the bone in a way that it's not normally used to being used. If we move back into the joint, we notice that there are a number of other structures that are involved here in keeping these joints together and then moving the joints. We have our tendon, which is attaching to the muscle, and the muscle is actually going to be the thing that's moving the joint, but the tendon is the thing that actually connects that muscle to the bone itself. So the muscle does not attach directly to the bone. Instead, what happens is we have the tendon making that connection between the muscle and the bone. Now, the tendon is not the flexible part. The muscle's the flexible part. The muscle's the part that's going to stretch and that's going to contract, etc. The tendon is going to be the hard part. It's almost like a metal wire that's it's not flexible. It's just attaching that flexible muscle to the bones. Now, in addition, inside the joint, we also have our ligaments, and the ligaments are holding the joint together. So the ligaments hold the joint together. The tendons attach the muscles to the bones. Let's take a look at some problems that can occur with those structures. We can have a strain. A strain is a tear or an injury that occurs in a tendon or in a muscle. Okay, so a strain is going to be a tear or in a tendon or a muscle. Okay, notice that's in a tendon or a muscle area. A sprain, though, on the other hand, is in a ligament. So depending upon what part is injured. Now, if we have a tear or an injury that's occurring to the tendon or the muscle, sometimes those will heal up, especially muscle pulls, etc., will heal up much faster than a sprain, which is a tear or injury to a ligament. So the ligaments being in the joint itself, they are going to take a little bit longer to heal up, and it's going to take a little bit more to get those to be good and functional again. So especially with sprains, oftentimes though also with strains, we may have to have the person do physical therapy in order to be able to strengthen those components again and to be able to get enough flexibility in those components again. An avulsion is complete separation. So we just tore the tendon off of the bone, or we tore the ligament from its bony attachment. And this is probably what you're seeing in most cases with people, with some of our athletes that blow out a knee or something like that. They're either totally tearing that ligament in half or tearing it from its bony attachment site. Recently, in the past year, we heard of an athlete who tore his, I believe it was the tricep tendon. So basically tore the tendon off the insertion site at the bone, so they have to go back in and they have to reinsert it. So surgically, they're going to basically sew it back onto the bone so that it can start to regrow back onto the bone. Tendinitis is an inflammation of one of our tendons, and then we have the possible degradation of our collagen fibers that can occur in tendinosis. Just as a very basic here, and the care, because you're going to hear about this from other people and you may read it or whatever as you're going through your studies here, but the basic care for sprains and strains, we call it the RICE. So we use an acronym RICE to describe the care that we use for sprains and strains, which is rest. Okay, so resting it, not walking on it, not, that kind of thing. ICE. Okay, so put ice on the area. Ice is better when we have an injury in its initial stages. So it may feel good to have that warm bath. It may feel good to put the heating pad on that area. But that's going to cause more inflammation while the injury is still fresh. So let's say, for example, you pull something in your back and your back hurts. Oh boy, does warmth feel good on that. But that's not going to be a good way to treat it, because that's going to cause more inflammation in the area, which causes more swelling and ultimately is going to cause you more pain and maybe even more dysfunction. So instead, we want to put ice on the area. Ice is applied only for 20 minutes at a time, can be applied a couple times an hour, but for 20 minutes at a time, and then it's going to decrease the inflammation in the site. Compression what they're showing here in the picture is that we have an ACE bandage on, or something that causes some compression over the site, which helps to further limit the amount of swelling that's going to occur. So if you go to the doctor because you sprained your ankle and they put an ACE bandage on your ankle, one of those elastic bandages, the reason they're doing that is to apply some compression. Then we want to have elevation, and that's being shown here as well, is we want to get that up higher than the heart. So we want to elevate the injured part higher than the heart, and it'll also help to decrease the amount of swelling that occurs in the area. You notice a lot of this stuff has to do with swelling, because swelling is going to cause more pain, more immobility, more disability in the long term for that injury. One of the worst case scenarios that can occur when somebody has a muscle injury is that the patient can end up developing what's called rhabdomyolysis. Rhabdomyolysis is caused by having myoglobin. Okay, that's one of the building blocks of muscle. Myoglobin is being released. So we damage the muscle. Myoglobin from inside the muscle is released into the bloodstream, and it's not supposed to be there, at least not in big quantities. And it gets into the bloodstream and it clogs up the kidney. So these big myoglobin molecules block up the kidney, and then they can cause the patient to develop some renal dysfunction. Crush injuries, compartment syndrome, things like that often are going to result in rhabdomyolysis. We can also see it in other situations where the patient has a lot of muscle breakdown. So any kind of big trauma or anything like that, we can end up with rhabdomyolysis. One of the key findings that we see in rhabdomyolysis is going to be this dark colored urine. They call it tea-colored urine because it kind of looks like tea, like you made a iced tea there. But the dark urine, we also get weakness and muscle pain as part of this triad we see of symptoms for rhabdomyolysis. Okay, so we have a 12-year-old female. She hurts her ankle while playing basketball. Tests reveal that she tore a ligament. This condition is known as. If you answered a sprain, you are correct. A torn ligament is also called a sprain. Another complication of fractures and of injury to our musculoskeletal system is compartment syndrome. Now, the forearm and the lower leg in particular, but there's also a number of other areas that can be a problem here. But the forearm and the lower leg are areas of the body where we have these compartments. There's the abdomen also has compartments, and so does the buttocks and the hand. But these are the two primary areas we're going to see a lot of compartment syndrome, is the forearm and the lower leg. Let's just take a look at a picture of this and we can get a better idea as to what we're talking about here. So here we have the muscle fiber in this patient here, and it's encircled by fascia. Now the muscle is flexible, but the fascia is not. In other words, the fascia does not expand and contract. It does not expand and contract the way that we might like it to happen. If we were to take the inside of, let's say, the forearm, or I'm sorry, this is lower leg here. We got the tibia and the fibula. So we take the lower leg here and we kind of slice the lower leg open so we can see it from the end. And we can see the different components inside the leg. This is what we'd see. So on the very outside, what you're seeing there is you're seeing fatty tissue, etc. Then we're starting to see some muscle, and you see all of these different compartments. Now these different compartments are all contained so that we can have complex motion occur of our forearm and of our lower leg. If we didn't have these different compartments, then what would happen is every time you moved a muscle, it would be rubbing up against other muscles and causing a lot of inflammation. So instead, we've broken everything down into these compartments, and the compartments are going to help to keep stuff from rubbing against each other and to keep it where it's supposed to be. Now that's very functional. Works well in the whole bit, except when we have an injury. So let's say we have an injury to the tibia in this particular patient here. Well, in that area, in that compartment around the tibia, we can have swelling. Now the swelling is not able to swell out into the leg as a whole it's swelling in that compartment, and that compartment can start to swell. Let's take those deep posterior compartments there. Those deep posterior compartments are injured from that broken tibia, so the tibia injured those areas as well, and they're swelling. Now they're going to start to swell into those posterior tibial neurovascular bundle and start to impact the nerves and the vasculature, and eventually we could lose blood flow to the leg, and the same thing can happen in the arm. That's what happens with compartment syndrome, is that the compartment is becoming swollen, the compartment is becoming inflamed, and it is starting to impact the neurovascular bundle, and it's starting to impact the neurologic innervation of that extremity and the circulation of that extremity. Okay, staying on this slide for a moment. If your patient had a fracture of the tibia and they had the swelling in that localized area, so we're swelling in those deep posterior compartments, doesn't it make sense that the first symptom you're going to see is severe pain? We have a broken bone, and the swelling in those deep posterior compartments are going to push on the fracture site, which is going to cause more discomfort. So the first sign we see, before we're going to see any decrease in circulation or decrease in our patient's neurologic assessment, is going to be severe pain at the fracture site that is out of proportion to the injury. That's how we know that this could be compartment syndrome. Then, later on, we're going to start to see some impediment in the patient's circulation, slow capillary refill, things like that. And eventually, we're going to start to see numbness and a loss of sensation, but those are very late signs. Those aren't early signs of compartment syndrome. When ischemia starts to progress in a patient with compartment syndrome, we can get what's called a Volkmann contracture. Now, this contracture you're seeing here in the picture is not the result of a fracture. It's just a contracture of the muscles as a result of having too much pressure in that compartment, which is then causing ischemia of the nerves. So here we have a diagram that helps us to understand, hopefully a little bit better, as to what's happening with compartment syndrome that's causing the symptoms that we see in our patient. So first we have the limb compression causing the local pressure, the local tamponade, and the muscle and capillary necrosis. That's causing edema then. Now, edema is going to make the whole problem worse. We already have compression. We already have pressure in that area. Now we're getting edema forming as well. That's going to increase the compartment pressure, and we start to get compartment tamponade, which causes muscle ischemia and more edema. Okay, see how we get into this vicious cycle? Over on the right-hand side, the compartment tamponade is going to cause neural injury to the nerves, causing a Volkmann contracture. The combination is going to cause a muscle infarction. In other words, the muscle is starting to die. We're going to get myoglobinemia, which can result in the patient having rhabdomyolysis and renal failure. An extracellular fluid shift causing shock. Acidosis with hyperkalemia, because potassium is going to be lost from the muscle tissue. Cardiac dysrhythmias as a result of having acidosis and a high potassium level. At the top part in the green there, we call that compartment syndrome. When we get to the point where we have muscle infarction, now we're going to call that a crush syndrome. Another complication or another problem we can see in our patients is called osteomyelitis. Osteomyelitis is an infection of the bone. Now, this would be very obvious as to why this would occur. If your patient has an injury, let's say the patient, for example, maybe was walking outside and fell, landing on her knee. Now, when she landed on her knee, she landed on a sharp object, a sharp piece of metal, and that sharp piece of metal went all the way up, and it cut through the skin and fractured the bone, and the piece of metal actually went all the way in and touched the bone. Okay, now we have an object from outside the body, potentially containing pathogens, that has now gone all the way down to the bone and has introduced that bacteria right into the bone. That's an exogenous type. We have an open wound outside the body, some bacteria from outside the body gets into the bone. We can also have a blood-borne infection where some of that bacteria gets stuck in the bone marrow and causes an osteomyelitis. Either way, we have a bone infection. Now, the problem is, remember again, that bone is very porous. And yes, it is very vasculature, but it's very porous. And the porosity of the bone is going to cause a situation where the patient may not be able to get antibiotics to the spot where that particular bone infection is occurring. So the patient in most cases is probably going to have to be on antibiotics for a long period of time, and in most cases you're going to have to receive IV antibiotics as opposed to taking them orally, because oral antibiotics are not absorbed into the bone very well. So here we have on the left-hand side showing an initial site of infection. So again, this patient fell down and the piece of metal struck the bone and brought bacteria from outside the body. We start to get this subperiosteal abscess that is starting to form. Pus is starting to form in there. The blood supply starts to become blocked. And then we're starting to see this actual infection that's occurring in the bone. One of the main, other than the fact that, first of all, this is going to be painful, the patient's going to have a fever and signs of infection and everything else. The other thing that's very important about osteomyelitis is the fact that it's going to weaken the bone. So this patient could have a pathologic fracture there as a result of having that infection. So not only do we need to treat the infection, but we're also going to have to treat the patient and keep the patient off of that. So they may have to splint the area, they may have to cast it or something like that to keep it from moving and keep it from getting injured while we're waiting for the infection to clear up. Okay, another question: which of the following clinical findings would be expected in a patient with rhabdomyolysis? If you said the classic triad of muscle pain, weakness, and dark urine, then you're correct. So the dark urine is typical of rhabdomyolysis. Malignant hyperthermia. It's kind of interesting that this is included in our musculoskeletal section. Malignant hyperthermia is a condition that it's an inherited muscle disorder, but most of the time where you're going to see this is you're going to see it in patients who've had anesthetics, so in patients who've had surgery. So after surgery, the patient then develops this malignant hyperthermia where they have these just massive muscle cramps as a result of being exposed to anesthetics, to anesthesia. So that's why the anesthesiologist is going to ask you about your previous history and any family previous history of having surgeries, just so that they can tell whether or not maybe you have this inherited muscle disorder. Now, if you do, and if the patient does have, there's a history of this in the family or something like that, then they're going to use a different kind of anesthetic to be able to do the surgery rather than the ones they typically use. The high temperature, so the hypermetabolism, the high temperature is caused by this severe muscle rigidity that occurs. So, you know, when you're cold, you get the shivers, and you shiver because shivering is going to increase body temperature. So causing muscle contraction increases body temperature, and that's what happens here. We get this prolonged calcium release, which then causes contraction, so we get this massive contraction going on. But that can lead to rhabdomyolysis and even death. Okay, with the temperature going so high, and the rhabdomyolysis and muscle rigidity can lead to death. So this can be a really important problem. Well, I bet this is a problem you've heard about before: osteoporosis. There's all sorts of ads on TV saying all you got to do is take this particular miracle drug or this particular herbal substance, whatever, and you will be able to keep your bones nice and strong and they won't become osteoporotic. What that means is we have porous bones, and bones are becoming more and more porous in osteoporosis because we're not able to adequately mineralize, in other words, get that calcium in and form that bone matrix and make it nice and strong. Okay, so here is a diagram showing the difference between normal bone on the left and our osteoporotic bone on the right. So you notice that on the left we have this nice solid matrix. On the right, the matrix is much thinner. So because that matrix is much thinner, it's going to make weaker bones are going to be more apt to having fractures. Some potential causes, well, obviously, hormonal level changes that occur during life are going to add to this because hormones are involved in the process of being able to absorb calcium into the bone and make strong bones, but also our vitamins and minerals that we are taking. Lastly, the decreased activity level, and here's how that works. Bones become stronger because we stress them. Bones become stronger because we stress them. The more you stress the bone, the stronger it's going to become. So just like any other part of the body, if you stress your muscles, they become stronger. If you stress your bones, they become stronger. So we want to stress the bone by some kind of activity that's going to cause it to build up a stronger, healthier bone. Now, in somebody with osteoporosis, maybe what they need to do is they just need to start a little walking routine or something like that where they can start to stress the bone a little bit at a time and try to rebuild that bone matrix. Some of the risk factors for osteoporosis, we can use the ACCESS acronym here. ACCESS leads to osteoporosis. Alcohol use, corticosteroid use. So your patients who are on long-term corticosteroids. Now we try not to use a whole lot of corticosteroids on a long-term basis anymore, but sometimes your patients do have to be on them, maybe for arthritis or maybe for some other kind of condition that's not controlled without using the anti-inflammatory properties of steroids. A low calcium. Okay, so again, and part of this is calcium intake. Part of this is the ability to be able to absorb calcium, so having an adequate amount of vitamin D. And we've played around with this for years. There's been research studies over and over again that have shown that, well, calcium supplementation helps, vitamin D supplementation helps, the combination helps. And I think the best evidence we have right now is a combination of calcium and vitamin D supplementation is probably the best kind of supplementation we can do at the time being. Estrogen has an effect on how well we're pulling our calcium and our nutrients into the bone and keeping them healthy. Smoking will also cause problems, and so will a sedentary lifestyle. So again, that sedentary lifestyle keeps popping up all over the place, doesn't it? So here's showing some different kinds of processes here that can occur in the bone and what the bone looks like in these different processes. Normal on the left-hand side, osteopenia, moving into osteoporosis, and then severe osteoporosis on the right-hand side where we have a very spongy bone matrix that's really not going to be very strong and could cause a lot of problems with the patient. Osteomalacia, on the other hand, is a situation where we're not having enough vitamin D to adequately absorb calcium from the intestine. And this is why they have supplemented milk with vitamin D to make sure that people are getting enough vitamin D in their diet. But if we have a number of different disorders, small bowel disorders, hepatobiliary disorders, or pancreatic disorders, those kind of situations can result in a lower amount of vitamin D being absorbed in the body, and therefore a lower amount of calcium that's being absorbed in the intestine, and then we get decreased mineralization of our bones. So this makes for soft bones. Not like osteoporosis where the bones are like Swiss cheese, but instead they're just very soft because they don't have enough mineral in them. And the end result could be that the patient's going to end up having kind of bone deformities, or the bones are going to deform under stress. So in this case here, the bones have kind of deformed because of the stress of body weight placed on them, and we get that kind of outward bending of the legs. Paget's disease is another type of situation here. And in this case now, this is a disorder of bone metabolism where there is an excessive amount of resorption of bone. And the replacement of the bone is more vascular rather than more marrow, which causes the patient to have weaker, larger, more disorganized kind of bones. And then this can result in the patient having pathologic fractures. And another problem that occurs with Paget's disease is that we can end up having a lot of calcium released into the bloodstream, causing a high calcium level in your patient. Although we really don't know the cause, it may have a viral process in nature, so there may be an underlying virus that causes this abnormality in the bone metabolism, but we do know that men are affected more than women. In milder forms, it just may be asymptomatic. We may not even know, but in more serious forms, we're going to get bone pain and fatigue. We're going to get that waddling gait that's starting to cause from bone pain, and especially because one of the areas of the body that's going to be affected is going to be the pelvis. The neurologic symptoms that we see here are going to be caused by these shortening and the changes in the bone structures. So we're going to start to see headaches, visual defects, and loss of hearing that can happen from our cervical vertebrae and the head starting to change its shape a little bit because of the bone abnormality, spinal cord nerve root compression, and again from the spine changing and the pelvis changing, and pathologic fractures because the bone, even though it's changing and becoming bigger, etc., it's becoming weaker, and we can have pathologic fractures occur as well. There's some things we can do here to diagnose it and try and find out if the patient has Paget's disease. Oftentimes we may see an elevated serum alkylase phosphatase, so an alk phos may be elevated. X-rays may demonstrate that there are some curvature or bone cortex is thickened and irregular. So some of those are some of the signs we may see. Bone scans, okay, that would be a good way to also detect that the patient's got Paget's disease. How about another couple questions? A 70-year-old female presents with a hip fracture secondary to osteoporosis. This condition is caused by an increase in bone. If you answered letter C, you're correct. Osteoporosis is due to an increase in bone resorption. 35-year-old female presents with impaired motor function and visual disturbances. The diagnosis is Paget's disease. What additional symptoms would be expected? Now here's one of those select all that apply types. Correct answer is, in Paget's disease, the skull thickens and assumes an asymmetric shape. Okay, so our correct answer there, the thickened segments of the skull may compress areas of the brain, altering our mentality and dementia. Impingement of new bone on the cranial nerves causes deafness. Headache is also common, but hypertension does not occur. Okay, so that was the incorrect answer there, would be hypertension. Osteoarthritis is also called a degenerative joint disease. So you may see this written in a patient's chart, degenerative joint disease or osteoarthritis, a non-inflammatory condition where we start to lose our joint cartilage and sclerosis of the bone underneath the cartilage, and we start to form some bone spurs in the joint. This makes it difficult for somebody to be able to walk and painful because of these abnormalities that are occurring in the joint itself. So we get local areas of damage. This is going to cause the patient to have pain, stiffness, maybe an enlargement, some swelling of the joint, tenderness, limited motion. Okay, this is one of the things you often hear about. The other thing you may hear about too is you may hear about some clicking or noises in the joint as the person is trying to move. Symptom-wise, again, systemic symptoms we can see pain, stiffness, rest, may relieve it at early stages, but later on rest is not even going to help. We might start to see some joint edema. We might start to see some nodes forming on the proximal joints in the fingers. These are kind of a hard, bony, it kind of looks like a wart, but it's hard and bony. A gait with a limp. The joints often affected are going to be the hands, the knee. Okay, here's a very common one. The hands and the knee is a very common one. The hips, the cervical lumbar vertebrae are also common areas where we're going to see osteoarthritis. Diagnostic studies, there's no specific test that can look for arthritis, but we can do a history of and look at the patient's previous history, past illnesses, etc. Look at some of their other things that are going on here to try and rule out rheumatoid arthritis or some other conditions. We can do radiographic studies, in other words, x-rays, arthroscopy, where you go into the joint and you look around the joints. So for example, a knee, let's say that we can't see a whole lot on our x-rays with the knee joint, so we go in there and we look around with the scope to really get a look at that joint. We can look at the synovial fluid to see if there's abnormalities in the fluid that's in the joint, and also do bone scans. Now, what this is showing here is it's showing the different phases and what happens with the process of developing osteoarthritis. Here we have the normal joint here in letter A. You start to see the breakdown of that joint and the narrowing of that joint that's starting to occur in letter B as the cartilage is starting to break down. Then we get to letter C, and our cartilage is mostly lost at that point in time. That's going to start causing some inflammation in the joint area. The bones themselves are going to start to deform, and they're going to start to have some changes that in the outgrowth of osteo sites in that area, but we're also going to see a lot of pain and swelling in that area. And that's you seeing the picture there of the patient's hand, and it's showing kind of those swollen, deformed joints. This is a osteoarthritic knee. So we have the normal knee on the left. You see the nice bone. You see how that bone comes down. It has nice edges to it, very nice and clear. Then we go over to the right-hand side. You see the osteoarthritic knee. And these knees are almost exactly in the same position when the x-ray was taken. But you can see the difference in the joints there. The joint on the right is very much narrowed, and the bone ends are starting to really become deteriorated with this arthritic process. Arthritis, on the other hand, is an inflammatory condition, and we're starting to have destruction of our synovial membrane, and the articular cartilage is starting to become so very similar to what we were just talking about here. So if it's an infectious process, can start this process. It can also be non-infectious, or it can be inflammatory, such as what's caused rheumatoid arthritis, for example, or even gouty arthritis. So gout or a rheumatoid type of condition is going to cause that to occur. In rheumatoid arthritis, we have an inflammatory condition occurring. It's a systemic autoimmune damage that occurs in the connective tissue, which is primarily in the joints, and it's going to attack that synovial membrane. The joint fluid becomes inflamed, and we have similar signs and symptoms that we see with osteoarthritis. Here is a picture on the bottom showing some of the sites that are affected by rheumatoid arthritis. It usually affects joints symmetrically. Okay, so you can see how this is more of a systemic factor rather than a wear factor. So we're seeing joints affected symmetrically, both hands, both knees, that kind of thing. We can look for rheumatoid factors. We can look for other types of things in our labs to help to tell us that the patient has rheumatoid arthritis. Really, though, pathophysiologically, the cause is unknown. It might be autoimmune. It might also be a genetic factor that's causing this to occur. As far as our symptoms go, you have morning stiffness, the weight loss, and you can anticipate this is a joint problem. So we're going to have decreased range of motion. ROM is an abbreviation for range of motion. You may see this written in a patient's chart or in the literature or some other place. Range of motion. Now that also means in other circles, like in OB, it means rupture of membranes. Okay, so some of our abbreviations you have to be careful of because they may mean different things in different contexts. In the context of evaluating somebody who's having joint pain and joint stiffness, ROM means range of motion. We have joint pain, warmth, edema, and erythema, which is redness at the area. So you can expect those kind of things in an inflammatory condition that is occurring of the patient's hands. Well, this is the end of part 1 of alterations in musculoskeletal function. Thanks for joining me. Let's move on to part 2 and talk a little bit more about our musculoskeletal dysfunctions.